Only mode.
Hello everyone and welcome. This is Michaela Conley, HP CareerNet and Health Promotion Live. Hope your summer is going really well. Glad that you're here. And today we have a long-awaited, I guess, webinar with Dr. Ron Goetzel. So let me tell you about Ron Goetzel. Ron Z. Goetzel wears two hats. He is the director of the Emory University Institute for Health and Productivity Studies, IHPS, and vice president of consulting and applied research at Thomson Reuters. The mission of the IHPS is to bridge the gap between academia, the business community, and the healthcare policy world, bringing academic resources and policy debates, academic resource into policy debates and the day-to-day business decisions, and bringing health and productivity management issues into academia. Dr. Goetzel is a nationally recognized and widely published expert on health and productivity management, HPM, return on investment, ROI, program evaluation, and outcomes research. Dr. Goetzel is the Dr. Goetzel is a task force member of the Guide to Community Prevention Services housed at the CDC, president and CEO of the Health Project, which annually awards organizations the prestigious C. Everett Koop Prize for demonstrable health improvements and cost savings from health promotion and disease prevention programming. And if you've participated in the past, you know that we've been doing for a while now the Koop Award Winner Series, which has been really, I think, a great thing. Gotten lots of great feedback on it because it really gives people an in-depth understanding of how people are, in fact, demonstrating their cost savings. So anyway, having said all that, Ron, are you ready to start?
I am, yes. Thank you.
Awesome.
Appreciate it very much. Well, welcome everyone. This webinar is going to be focusing on a new phenomenon called workforce health indices, with the idea being that employers are interested in measuring and improving their workforce wellness and productivity. And so to give you a little bit of context about what this is all about, what's a workforce wellness index? Well, there are two distinct categories. One is that it's a qualitative tool to assess the extent to which an employer or worksite has adopted a best practice in population health management and population health improvement. So essentially, it's looking at all the different elements and ingredients, structural and process and policy issues that would make a company a healthy company culture. The second type of health index is a quantitative tool that aligns employee health risk factors and profile with outcomes of interest to the organization, such as medical care costs, worker productivity. And then the derivative from all of this is the idea that it would produce a single number that reflects the interaction between population health risks and costs, and that number could be compared and contrasted over time. So the origins of this came from several of our employer clients who said, we are inundated with data. We get reams and reams and reams of reports of data, and all of that is incomprehensible to the senior executives of our organization. They want to know a single number. They want to know how the health of the population is and how it compares with the financial health of our organization. Can you somehow bring these two together in some way so that all they have to look at and all they have to worry about is one number? And so that was the challenge that was posed to us, and we went about trying to figure out how to do it, and in this presentation I'll show you some examples of that. All right, this is a list on this next slide, some examples of qualitative tools that measure organizational structural and process variables that support a healthy company culture. For example, the one that's probably most widely known is the HERO Best Practice Scorecard, and I'll show you a picture of what that looks like in a minute. The National Business Group on Health has a wellness scorecard called the WISC, W-I-S-C. We're now working with the National Business Group on Health to connect actually 3 different data collection methods. One is called EMPAQ, E-M-P-A-Q, which is this annual survey of the employer population, the WISC score, the wellness score, and then HEDIS scores to come up with essentially even more comprehensive scorecard that employers can use. There's the CHEW instrument that was developed by Jim Salas many years ago that looked at environmental supports for healthy lifestyle. There's the Employer's Health and Productivity Management Inventory, or the Hpm Inventory, and I'll show you a picture of what that looks like, developed by Emory University. There's the Environmental Assessment Tool, developed by University of Georgia and Emory. Leading by Example, Leadership Support Tool, developed by Emory and UGA. There are international tools like the Healthy Employees in Healthy Organizations tool, developed by the European Network for Worksite Health Promotion. New York State specific tool that is called HeartCheck. HeartCheck Lite, developed by Fisher and Golajewski, and the Well Workplace Checklist, developed by Welcoa. So there are lots of these, and this is not a complete list even of all the different tools that are out there that measure qualitatively the worksite. Here are some examples of what these look like. This is just a screenshot of the HERO Best Practice Scorecard. This is something that the Health Enhancement Research Organization developed. It's working with Mercer to accumulate data and report on those data. I think they've got data now in about 500 different employers. This is an example of that report that looks at leadership engagement, and there are 6 different categories in the scorecard, and employers can earn as much as 200 points. This is a screenshot from a tool that we developed called the Hpm Inventory. A very similar idea where employers indicate that they have these programs, policies, and practice in place. They've got the smoke-free workplace, well-lit accessible stairways, bike racks, changing facilities, things like that. And they essentially get a point, a score, for every one of those things that they have. The Leading by Example assessment is an instrument that we developed actually as a baseline, as a foundation for this, used something that was developed by George Pfeiffer and Gary Lindsay and Partnership for Prevention. If you go to their website, there's an area there for under Worksite that is called Leading by Example. There's an assessment tool, an instrument that they developed. We took it a step further, modified it, enhanced it, and then conducted a series of psychometric studies and psychometric analyses looking at the validity and reliability of the instrument. Lindsay Bella, who's the lead author on this paper, also wrote 2 other papers focused on the LBE, and it's now being more widely used because, again, it's been shown to be correlated with actual changes in environment and policy and leadership support. This slide basically shows you the items on the LBE, and there are different versions. The one that's published is the 13-item LBE, and basically it boils down to 4 different factors that indicate leadership support and engagement in healthy company culture. The environmental assessment tool, or the EAT, so you'll see that there's the CHEW, the EAT, and down the road there may be the BARF, you never know. But this is an assessment tool that built upon the CHEW and allowed for the scoring of environmental support systems and structures and programs. The tool was built as an observational tool so that people actually went on site and counted items in vending machines that were healthy choices, looked at staircases, looked at bike racks, looked at fitness centers, cafeteria offerings, signs, and all that stuff, and then put it into a scoring grid. This was developed in a collaboration with the University of Georgia and Emory University. And here are, again, some example items from the environmental assessment tool. You'll, again, find a lot of correlation, a lot of similarities between the EAT, the CHEW, the HERO scorecard, and many of the other instruments, because they get at many of the same issues that are relevant to providing a supportive environment for healthy lifestyle. This is a project that was developed by the Change Agent Work Group. If you go to Google and plug in Change Agent Work Group, you'll see, actually you can download an entire toolkit. This is an example of the assessment tool that's used, and it allows organizations to determine, where they are in the process of providing healthy company culture, whether they're in the early phases or the later phases, depending upon how many of these different things they have in place. And again, you'll see a lot of comparisons and parallels between this tool and some of the other tools that are out there. So with all of that as background, we conducted a project for the Centers for Disease Control and Prevention, the CDC, a couple of years ago, where we went out to look at various health indices. And essentially, a lot of these kinds of assessment tools that were out there, the purpose was to figure out the landscape, kind of who's doing what, where, and how, what the needs were from an employer standpoint, who was involved. Was it health plans? Was it academics? Was it vendors, employers? Who was doing this kind of work? And then to help the CDC to determine whether they needed to create their own version of this or not. So the Worksite Health Index project looked at what employers are looking at. Well, I'm using the word looking. Looked at what are the essential ingredients for successful health promotion programs. The initiative goals were to develop this tool that could be used by employers of all sizes, but primarily smaller employers who are doing very little in the area of worksite health promotion, to look at workers' health risks and risk factors, policies, programs, environmental supports, and culture, and other relevant areas that led to success of these programs. What they hoped to do was to provide employers with immediate feedback and also give them a link to other additional tools and resources that they could use in improving the environment for health. Here's a listing of the various stakeholders that were called together. We conducted a literature review. We went to published articles, but we also went to websites, to conference presentations, and a whole host of different places to try to find out what was the state-of-the-art, state of the science in worksite health indices. The stakeholder panel included people in public and private sectors. And the approach to the project was to first do this environmental scan, to develop the health index by finalizing domains, the indicators, the metrics, build and pilot a prototype, and then eventually, and this is where we're headed towards, is develop a web application and disseminate that so that they can take some of the best practices and knowledge that's out there and actually make it available to employers. Our analysis that included this literature review and stakeholder panel and all the rest, we came up with 25 subcategories of essential elements or essential ingredients for positive healthy lifestyle, healthy culture at the workplace that would support a healthy lifestyle. They fell into three broad categories: leadership and corporate culture, program design and implementation, and program evaluation. This was, by the way, a follow-up to other benchmarking studies that have been conducted by the CDC and by other organizations going back more than a decade. In fact, the American Productivity and Quality Center in Houston, Texas, conducted a benchmarking study, a series of benchmarking studies. Michael O'Donnell was involved in some of them. We were involved in others. But we went out even back in the 1980s and 1990s to find and identify the best practices out there. And also to figure out what were the central themes that are associated that made them best practices. Now, I'm not going to go through these in detail, just to give you a sense of what some categories or concepts in best practices were like. This is the first domain, which is leadership and corporate culture. You need to have leadership and management support, organizational culture and policies that support healthy lifestyle, alignment of the business and health goals of the population, wellness champions, sustainability that is kind of a long-term view as to where the organization should be headed. In the second domain, there are many more categories of best practices in the area of program design and implementation, planning and program goals, diagnostics and assessment mechanisms, integration of data systems and informatics, the use of incentives, the wise use of incentives, providing adequate resources, providing multi-component interventions and effective implementation, tailored interventions, effective screening and triage, piloting the programs, getting involved with the local community, accessibility to benefit programs and policies, reducing barriers. Assuring confidentiality, providing environmental and ecological interventions, effective communication, making health benefits, insurance plan design so that it also dovetails with healthy company culture. And then the 5 remaining categories fell under Domain 3, which are program evaluation, measurement and evaluation, effective tools, accountability for the metrics, learning from those results, and making it a learning continuum so that there's constant improvement in the process based upon the data and evidence that is accumulated over time. And finally, economic justification for the program, especially relevant in employer-based interventions. So I went through these 25 very, very quickly. You can always go back and look at these more carefully and cross-reference them against some of the things that you're doing and some of the initiatives that are out there. Also, NIOSH, which is the National Institute for Occupational Safety and Health, has on its website what is referred to as essential elements of successful worksite health promotion programs, and those two align with these 25 different categories. Now, out of this work came a derivative instrument which is still in development. It's actually in the last phases of development. This is something developed by the CDC called the Cdc Health Scorecard. It touches upon 12 different domains that are relevant to cardiovascular disease, but also touches upon things like diabetes prevention, depression, stress, and so forth. And what this process has led to is the development of a simple yes-no type of scoring instrument that employers can use to assess the extent to which they have a healthy environment that's supportive of cardiovascular health. So it doesn't touch upon cancer risk. It doesn't touch upon other categories that are relevant to population health, but it still covers a lot of ground. There are 100 items in the scorecard over 12 different domains. And again, this is something that is in the final stages of being developed. Hopefully will be available in the next few months. Some other exciting developments. There is a lot of work going on in developing quantitative health indices. And I'll give you some examples from Novartis, from PepsiCo, from Thomson Reuters. And I'll end with an example of an international application of a health index that was put in place by Discovery Holding, which is the largest health insurance company in South Africa. I'm going to be switching gears now to the quantitative side of the equation from the qualitative. The qualitative, as a reminder, is looking at all the structural elements that are necessary to produce a healthy company culture. This quantitative approach begins to actually assign numbers to the health risk of the population connected back to financial measures. And if you're interested, we've published some articles in the Journal of Occupational Environmental Medicine focus on the development and implementation of these wellness indexes or health indices for Pepsi Bottling Group and Novartis, and the references are shown here. So for both PBC, which is Pepsi Bottling Company now, used to be Pepsi Bottling Group, now it's Pepsi Bottling Company, and Novartis, the idea is that you want to show a relationship between the health risk profile of the population and measures or metrics that are important for the employer. And they include medical, prescription drug, workers' compensation, short-term disability, absenteeism, and presenteeism, showing how these things are connected to one another, and then linking those things so that you can produce the single number that everybody wants, kind of the health index number that you can keep track of over time. In terms of the process that we went through in developing these health indices, there are 4 phases. The first is to just look at the data descriptively. What are the characteristics of the employees who are at high risk versus low risk, and connect that back to financial measures. Second phase was to conduct more sophisticated multivariate studies to show the direct relationship of the risk factors and financial outcomes, but controlling for confounders, controlling for multiple risks, controlling for demographics, and so forth. Third phase is to publish findings to make sure that they're credible and their peer reviewers have looked at the approach and have said, yeah, this makes sense. And then finally, what the organizations are looking for is a tool that they can use that is something where they can plug in data and then on an ongoing basis look at the effects of their interventions on their health index scores. So examples, with Novartis, the first step was to take all of their data and to create an integrated database that was connected at the person level. So one analytic file, you connect eligibility data, medical claims data, pharmacy data, health plan enrollment data, which is the same as eligibility data, health risk data. In this case, we use the Mayo Health Risk Appraisal. Also, there was a measure of presenteeism or productivity using the Work Limitations Questionnaire developed by Deb Lerner at New England Medical Center, Tufts University. Incidental absence data and short-term disability data. So you actually had all of these data connected at the person level. Looking at the risk profile, here what we have is the prevalence of the proportion of the study population that's at high risk when the sample was taken. And you can see that about 80% have risk for poor eating habits, 70% for emotional health risks, about 50% with weight risk, so forth and so on, and a general health indicator, about a third of the population having overall general health risk. And if you connect this now to any one of the measures that are out there, in this case we're connecting it to productivity, the WLQ scores, and then just comparing the people in terms of general health for those at low risk versus high risk. Again, about a 2/3 population at low risk, 1/3 at high risk. You can see that the proportion of productivity loss, as well as a translation of that into workdays loss, is statistically significant. In fact, people at low risk, on average, are losing about 3 days a year due to presenteeism, to those at high risk at about 5 days a year. So about a 2-day difference in terms of high versus low risk in general. Now, in the case of Novartis, what we did was we looked at all the risk factors and we conducted something called a factor analysis. And what that is statistically looking at the clumping of risk factors together. So which risk factors tend to congregate with one another based upon the likelihood that people will have those risk factors. We ended up with 3 broad factors. The first was a biometric risk factor that included such things as you would imagine overweight and obesity, high triglycerides, high cholesterol, high blood pressure. And then the second risk factor was alcohol and tobacco use. So people who were smokers were also more likely to have consumed excessive amounts of alcohol. And a third risk factor was in terms of emotional health risk. And as you can see, we looked at this separately for males and females. It turned out that there were different kinds of relationships that were taking place for males and females across these risk factors. Just as an example of how these risk factors, or the factors, the broad factors, influence outcomes, this is an analysis that looks at risk factors for females and males, high biometric risks, alcohol, tobacco, and emotional health, showing a statistically significant increase in medical expenditures for both males and females when they had those risk factors. The middle risk factor, alcohol, tobacco, did not turn out to be statistically significant in terms of predicting higher medical costs. But if you look at presenteeism, all of the risk factors for both males and females turned out to be statistically significant. In fact, the presenteeism was increased from anywhere from about 116% for emotional health in females all the way up to 224% for alcohol tobacco use for males. So you can see that in all of these categories, having the risk factor increased the presenteeism outcomes, in this case kind of increased presenteeism and reduced productivity in the workforce for those who had those risk factors. The other example we have here is, well, I take it back. This is the publication that emerged from that analysis. We then took these data and created an Excel spreadsheet so that you could take the results of the analysis and plug them into an Excel spreadsheet and then begin to play kind of what-if types of games. And so the model inputs include demographics of the population. The what-if part of it allows you to say, well, what if I made a small, medium, or large risk reduction in the population? What would that do? And the outcomes included all the different outcomes that were of interest in the analysis. We looked at a lot of different things. I'll just show you a sampling of some of the things that were used in the model. So this is what a screenshot of that model looks like. You're able to enter the population size, some demographic information about the population, and then the risk profile of that population. It also allows you to change, if you want, any of the expenditure variables that are there. Those are taken directly from Novartis, but if there are changes, you can alter those inputs. This slide shows the opportunity to do this what if. You know, what if you wanted to introduce changes in the risk profile of the population for males or females in each of these broad categories, biometric, risk, alcohol, tobacco, and then emotional. What might that do in terms of affecting costs? And then it does do this kind of calculation saying, you know, if you made these changes, here are the kind of financial impacts that we would expect from risk reduction in the population. Here it's doing it for 3 categories: medical, absenteeism, and presenteeism. And then the really, really nice part about this is this kind of graphic, which takes all of this information and then creates this magical number called the health index number, or the health index score. And essentially what this means is that you can determine a number that's between 0 and 100 that tells you what is the relationship between the risk profile of the population and a series of different financial metrics. In this case, we're looking, again, medical, absenteeism, presenteeism, and looking at how that might shift over time if you're able to change that health index number. In this example, we're saying the baseline health index is 79. That translates to about $7,000 in per employee per year costs. But if we were able to move that index number up to 81, that is, improve the health risk profile by reducing risk, then the total expenditures would be down to $68.41. These are inflation-adjusted numbers. So this allows the organization to kind of keep track of how it's doing on both risk and cost. The other example is Pepsi. Similar idea where we looked at their data and then connected it back to financial measures and published our results. This is just one example of the connection between risk and cost. In this case, looking at BMI, overweight, and obesity, and essentially looking at 5 categories of weight. There's the normal weight group, overweight, class 1, 2, and 3 obesity, and those are established at BMI levels of 25, 30, 35, and 40. And what you can see here is that in each of the categories that are measured, medical costs, short-term disability, workers' comp, presenteeism, absenteeism, as you move up from normal weight into overweight and obesity, the costs increase as well. And in fact, if you add them all together, for a Pepsi bottling company, about a $1,000 difference between normal weight employees and those that are overweight or obese, and that's about a 25% differential. Once again, you take all this information and create this very nice Excel spreadsheet. This one is actually harder to read than the one we showed a minute ago, but the same idea where you plug in the demographic information, you plug in the risk information. You're also able in this spreadsheet to plug in the intervention costs. That is, what you think, what you know the cost will be for the risk reduction program, the baseline costs, and then compare it to either a national norm for Pepsi, or you can do it by division, business unit, and location. And it then does a calculation based upon the risk reduction that you've plugged in. And in this case, it's an across-the-board 10% risk reduction. You should note that there's a difference in percent risk reduction versus percentage point risk reduction. Percentage point risk reduction means that you go down a whole percent. Let me give you an example. If let's say, the obese population is 30%, a percentage point drop would mean that you go down to 29%. If it's a percentage reduction, and let's say it was a 10% reduction from 30%, that would be a 3 percentage point reduction. So it's important to get those terms clear when you're designing these models and also explaining it and applying these different models. Here we also show the health index score for the company, and it also does calculation of return on investment, assuming you're able to achieve these kinds of risk reductions in the population with a certain investment value. And what Pepsi is interested in doing is creating a comparison, an internal benchmarking project, so that it can compare different locations one to another and reward those locations that are doing a great job in risk and cost management, and spur on those other locations that are not doing such a good job to move to at least the company benchmark and eventually improve upon that benchmark. So it's an internal benchmarking study that they're using. Now, Thomson Reuters has also moved into the health index business. We did this with all of these other studies as background, and the idea is the same, which is to connect the risk factors in a population to healthcare and productivity costs. As a first step, we focused on healthcare costs. Now, the advantage of doing this through Thomson Reuters is that you've got a very, very large normative database called MarketScan. In this case, we had data in MarketScan that went from 2005 to 2009. We're now in the process of updating the data to include 2010 data. But there are about 25 million covered lives in the database just in 1 year. The database includes eligibility, medical claims data, and a lot of very, very micro-level detail about disease and disease severity. Alongside the MarketScan database is also this HPM, or Health and Productivity Management database, that contains health risk assessment data. And when we looked at it in 2009, there were about 2 million people in the HRA database. So the idea is to link the HRA database back to the MarketScan medical and drug database and use those data to do this kind of connection between health risk and cost. We constructed 2 indices. One was of the MarketScan population, and then we also developed a U.S. index which was based on external normative data. Now, the complication of doing this in MarketScan is that you've got many, many different HRA instruments, and by and large, they don't communicate with each other, and they use very different standards, different operational definitions for what defines risk. And so you're a lot more limited in terms of connecting all of these together and doing kind of a cross-risk analysis. Normally, when you do these kinds of studies, you're focused on 10 or 11 risks. Here, there were 6 risk factors that you could create common definitions and common operational definitions, and they were BMI, glucose, blood pressure, cholesterol, tobacco use, and alcohol use, where the definitions for high risk are fairly well known. Stress and exercise were 2 other categories that you could look at the MarketScan database, but there weren't comparable data in U.S.-based survey instruments like the Behavioral Risk Factor Survey. So here's just an operational definition of inclusion-exclusion criteria for who were in this database: full-time employees 18 to 64, non-capitated healthcare plans, continuously enrolled, and non-pregnant. And here were the operational definitions that we used for the risk factors of interest. So BMI, high risk was BMI greater than 30, blood pressure 140 over 90, one of the two, high cholesterol, total cholesterol over 240, high total glucose over 126, tobacco use, basically you're smoking cigarettes or using any form of tobacco, more than 2 drinks a day for alcohol use, sometimes or often feeling stressed, and not exercising enough, less than 2 days a week. Now, and this is kind of techie, but because the MarketScan database is not representative of active employees in the U.S. population, we adjusted the weights based upon how the U.S. population is distributed in terms of an active workforce, using current population survey data to basically weight the data accordingly. But that's just a micro detail. The important part here was that we use regression methods to establish the importance of each of the risk factors, looking at its effect, subtracting out the effects of having certain illnesses to begin with. And this is very, very tricky to do. So for example, if you're looking at the effect of blood glucose or cholesterol or overweight, what you want to do is subtract out diseases that are there even before those risk factors appear. And so you're trying to control for other risk factors, comorbid conditions, and employee demographics when you're estimating the independent effect of the risk factor. And kind of a full explanation of how that's done would take a lot longer than what I just went through, but and we're going to be writing up a paper that describes that in a lot more detail. This is where we got the normative data for the U.S. Out of the Behavioral Risk Factor Survey, as well as the National Health and Nutrition Examination Survey and Haynes. And this is what the results looked like in our first pass of the analysis. So what you're looking at here is the health index score, 2005 to 2009. The orange is the MarketScan group. That is, these are employers who are in the MarketScan database. You can see that their scores started a little over 84 in 2005. There's a little dip there in 08, but by 2009, they're going up to close to a little over 86. On the other hand, the U.S. Wellness Index is actually dropping over time, starting at a higher point, about 86 or so in 05, and dropping to close to 84 in 09. So we're seeing kind of an inverse trend for the U.S. employee population versus the MarketScan group. And so this summarizes it in a narrative. And a lot of this is due primarily to overweight and obesity, BMI, which is really the biggest driver here in terms of increased risk and increased costs. high BMI contributing the most additional dollar amounts in terms of medical care costs compared to the other risk factors that we're looking at. Let me close, because I want to make sure I have enough time available for questions. Let me close with a really interesting project that we did and we continue to do with Discovery Holding, which, as I said, is a South African health insurance company. They were interested in identifying the healthiest companies in South Africa and kind of getting the word out that companies can play an important role in improving the health risk profile of the employed population. In South Africa, there's a certain segment of the population that is enrolled in private insurance plans, and those plans are not very different than U.S.-based health insurance plans. They cover the same kinds of services. They are as comprehensive, as expensive. There are some differences in how ratings are done there. They're community rated versus individual rated, but that's that's neither here nor there. What Discovery wanted to do was to have this essentially an open competition among employers to see who might be identified as the healthiest company in South Africa in the year 2011. So this was interesting because it essentially combined these two ideas of a quantitative and a qualitative assessment. On the quantitative side, they looked at employee health risks, and they measured those health risks through surveys that they administered, looking at something called vitality age that includes factors like high cholesterol, high BMI, smoking, physical inactivity, high blood pressure, poor nutrition, other factors that are included in there, and they're able to calculate essentially a vitality age for the population. This is an example of what the results were across 100 employers. The proportion of the population, about 26% obese, a third overweight, and then the balance being either underweight or healthy weight. And alongside that, we have a measure of nutrition or diet, looking at the number of fruits and vegetables consumed per day and the proportion of people in those risk categories. This slide shows the organizational health indicators, and you can see that this is very similar to what we talked about earlier in terms of HERO scorecard or the Hpm scorecard, but essentially looking at different kinds of programs that the company offers to its employees to improve population health. And then this should look familiar as well. This is an indicator of leadership support using many of the items that are in the LBE or leading by example instrument. So taking all of these different measures together, Discovery, with 100 or so applicants for the award, designated these top 10 organizations as the healthiest companies in South Africa. And none of these names will sound familiar to a U.S. audience. BSG is, interestingly enough, a very small computer programming software company with about 170 employees, but very, very health promotion oriented. And they won the top award of South Africa's healthiest companies. There's a lot of media recognition and Discovery Health Vitality is planning to continue to do this on an annual basis. So to summarize, on workforce wellness indices, there certainly, as you can tell, there are lots of them out there. I just gave you kind of a smattering of some of the instruments that are out there. Some are qualitative in nature, others are quantitative in nature, and yet others yet are both, as the example as was done in South Africa. The aim of these indices is to connect organizational health, individual risk factors, and financial metrics. The goals are to come up with this one number that reflects a composite health and cost score for the organization, kind of like the Dow Jones Industrial number, which we hear about on a daily basis, which really is no more than an indicator of stock prices for 30 companies as opposed to the overall market. But it's the one number that most people pay attention to. And what it does is measure the impact of improving behavioral risk factors on healthcare costs in employee population. So as you are able to improve the risk profile of the population, that in turn improves the financials for that organization and then improves the risk score or the wellness index score for that organization. And with that, I will turn it back over to you, Michael.
Excellent. You certainly covered a lot of ground. So I think, yeah, if you have questions, go ahead and type them into the question box, and I will get through as many of them as I can. Let's see. Somebody who refers to themselves as RJ, just FYI, he or she wanted to say that, Ron, you may be the most influential character in creating practice/statistical bridge in the well-being maximization in the world today. He said, exciting to be here. So there, take that. See, I told you when we rescheduled this that you had definite Goetzel groupies. So I think that's awesome. Okay, so let's see.
My album is coming up next year.
I'm sorry?
A new album is coming out next year.
Awesome, like greatest hits? That'll be really cool.
I'm just kidding, okay.
Of course, now the pressure's on. Let's see. Bill McPeck, hi Bill, wants to know, does the employer size play a role in arriving in the employer's index score, or is it based solely on what the employer offers in programming and services?
The size does not matter. So the work we're doing with the CDC, we have data from very small employers, under 100 employees, small, medium, and large. And in fact, we're finding a lot of small employers are doing this. We did some site visits. We visited one employer in Maryland that had about 50 or 60 employees, and they were really gung-ho and trying to introduce a lot of these programs into their workforce. But many employers, in the under 500 group are beginning to do quite a bit in this area.
Super. Let's see. Gail says, thank you for the great information. Am I correct in thinking that the CDC Worksite Health Index is not available yet?
That's right. It is not available yet. We're in the process of finalizing. We've done a lot of work on content validity and other validity measures and reliability assessments. So we've spent about the last 2 years working with the CDC to make sure that it's a good instrument, it's a valid and reliable instrument. We're hoping and expecting that in the next 3 to 6 months it will become available through the CDC free of charge.
Super. Let's see, a couple more questions from Bill. Bill's always a good questioner. How is the safety risk measured and calculated?
Well, safety in this context is very, very, very limited. It is not kind of OSHA safety that people normally think about. Here, it's primarily automobile safety, which is wearing seat belts, not speeding, not drinking and driving, wearing motorcycle helmets. In the case of South Africa, they also asked about cell phones and pagers and Blackberries and those kinds of things, whether people are using handheld devices or not. So that was a question that they asked about. But those were the main factors in looking at safety. Some other times, employers look at home safety, like fire detectors and carbon monoxide detectors, things like that.
Super. Let's see, here's another question from Bill. How do you see the Workforce Wellness Index being used by employers in conjunction with the Gallup-Healthways Wellbeing Index?
Okay, yeah, and that's a good point. I didn't mention the Gallup-Healthways. There is a section in the Gallup-Healthways Wellbeing Index that does address employers and the culture and employer environment. So I would just say that it is another tool that employers can use, another index, because it assesses individual risk factors as well as the employee's perception of the workplace environment. It is filled out by the individual worker. It is not filled out by the people running the program. So in that sense, it's a little bit different, but it is fairly comprehensive, and it does cover workplace culture in addition to individual risk factors.
Super. Here's another question from letter R. Ron, can you comment on the work that you've seen and are doing regarding to extrapolation of cost savings to the total U.S. population, given nearly $3 million annual $3 trillion in annual expenses, and how much of the cost could be saved if, say, 1 million of our 3 million population would engage in an average amount of healthy behaviors?
Well, go
ahead.
Yeah, I get the general gist of the question. There are a number of calculators out there. In fact, there's a project that's going to be beginning soon that Health and Human Services is going to be funding, looking at the various financial modeling tools that are out there. We have an ROI calculator. There is an obesity cost calculator that's on a CDC website called LeanWorks. And there are several others out there that have been developed that try to predict what the savings might be from risk reduction programs. And these health indices in many cases do that as well at the individual company level. Kind of broadly speaking, what do I think can be saved if the population as a whole led healthier lifestyles? I don't know. I think certainly a big driver of cost has nothing to do with lifestyle. It really has to do with healthcare utilization and cost of services. As we use more technology, we use more services. We do know that 3/4 of all of our spending in the United States is consumed by chronic disease. That is, people who have chronic disease conditions like diabetes, like heart disease, like asthma, and so forth, mental illnesses. So to the extent that you can manage those chronic illnesses with health promotion, you will be making a dent at 3/4 of our total spending. But in terms of coming up with an actual number of how much of the $3 trillion will be saved, there are some estimates. Actually, there's an estimate that says about a third of all of our spending is wasted, and in a variety of categories. But I think that's probably close to accurate. If you look at all the different things we can do, including health promotion, probably save about $1 trillion.
Mm-hmm. Yeah, just for clarification, you said, in other words, could healthy citizens literally pay off the national debt? It sounds like it could work in theory.
Yeah, in fact, there was an analysis done looking at Medicare beneficiaries, and basically said that if you could get Medicare beneficiaries to come into Medicare healthier, instead of 3/4 of them being sick and having chronic disease, if it was down to only half or so, then you could save trillions of dollars in Medicare alone. So the answer is yes. Again, I don't have the exact figures in front of me, but in general, if you can get the population to adopt healthy lifestyles, especially directly in terms of Medicare programs, you could save a lot of money.
Let's see, this is from Leslie. She says, your model appears to be built on single company statistics. Have they been tested, validated against other company data and outcomes?
Well, the models that have been built have been internally tested. So Novartis, for example, tested its model with its own data and found it to be pretty predictive. There are general models out there that use data, for example, from the HERO study, which combined data across 6 different organizations. And those models are used quite extensively and are generalizable to larger populations rather than a single employer. We're in the process now of publishing an update of the HERO database, and we're hoping that that will, in turn, allow us to develop, again, a more general model of risk reduction and cost savings. So the answer is yes, that there are those models out there. They're still probably in their infancy. They can stand improvement. And I hope in the next few years there will be kind of new, advanced, more sophisticated models and more predictive.
Great. Let's see. Elena would like to know, will the CDC be publicly reporting on the index data?
Will CDC be publicly reporting what data?
The index data.
Oh, all right. That's the idea. Yes. So that when data are collected, there'll be essentially kind of a surveillance system that keeps track of this. How exactly that's going to work is something that's still being discussed. But my vision would be that it would be similar to kind of the behavioral risk factor survey or NHANES database, which would report on a regular basis kind of what the what organization, what employers are doing in terms of creating healthy company culture.
Oh, that's awesome. Let's see here. Does the company's location and/or surrounding environment affect their health index?
Yeah, I mean, location does affect the health of the population. We know that there are certain parts of the country, for example, the Southeast, where the health habits are much worse than other parts of the country. Colorado, Washington, Minnesota, those states typically have better health profile and lower costs, whereas the Southeast, by and large, and some other communities, most especially correlated with socioeconomic status, have worse health profile and worse rates of chronic disease. So yes, the location of the organization, I think, does matter.
Okay, I have time for, I think, one more from Lisa, and she said, would you please elaborate on why incentives not tied to biometrics are recommended in a qualitative assessment? She said the New Mexico Department of Health agrees, and she'd just like to hear your reasoning.
All right, this is a very, very complicated question, and it has to do with this whole issue of incentives and how incentives are structured, and are they related to participation, are they related to outcomes? There's a lot of discussion and controversy about this issue. CMS and Medicaid are actually starting a demonstration with various states around the country to test out various models of incentives. Certainly employers are beginning to put in place a whole variety of different incentive structures. I think the jury's still out, and it's too early to say which configuration is going to work the best.
Well, let's see. Okay, maybe you can answer this one fairly quickly, or, take your time. I'm not going anywhere. Let's see. Elena again wants to know, can you speak to the rationale for using an index versus a categorical rating, such as report card grades?
It can be done either way. In fact, we are experimenting now with grades, A to F grade, for example, in one of the indices that we're developing. So that is another approach that we're exploring. People like numbers, so an 81 versus an 82 is, you can kind of get your arms around what that difference is versus an A versus a B. Obviously the range is much greater. But we're beginning to explore both. In fact, we may end up with both categorical as well as interval rating scale.
Super. All right, well, Ron, I think we've run out of time, and I really appreciate you being here. Great information, and I hope you'll come back and continue to talk about this topic, because there certainly is a lot of things going on around it.
All right, you're quite welcome, Michael, and thanks so much, everyone, for attending. Appreciate it.
Take care, everyone. Have a good weekend. Bye-bye.
All right, bye-bye.